Well, thanks very much, Governor. Appreciate the kind things you said, even though you reminded people that we first knew each other when I was a very young lawyer. And along those lines, I have always been a volunteer lawyer for the State Democratic Party. The way I got into healthcare was that my day job for many years was in the private practice of healthcare law. Actually going back to when it was called hospital law, because no one had thought of the fact that we're dealing with a whole system governed by law. And gradually, sometime in the late 80s, they started calling it healthcare law. I do also want to thank Barry for having us here today. I want to thank all of you for being here, and it's great to be with this wonderful group of panelists, all of whom I'm looking to hear from. This is a little bit of role reversal because usually, it's a lot of role reversal. Usually, I get up and say something very broad, and then the people who really know something, like David, get up and go into the details. Afterwards, often working with other very smart people, such as our Vice President for Public Policy at Tufts Health Plan, Kristen Lewis, who spent each of you has spent a lot of time talking to. Or I see I hear the future from Professor Herzlinger. This time, I'm going to drill down a little bit on what David talked about, and then hopefully later on, after everyone has done their sort of scene setting here, we will have some good dialogue on what this is all about. We have a number of things that make Massachusetts unique in healthcare. Some of them are very good but very expensive, such as four medical schools in one state. Every medical school has to have an academic medical center where they do research and teach. That is doesn't just cost a lot to run those places. It sets a lot of the tone for the way things are done in medicine, and that gives us a lot of high quality. It also gives us a lot of additional expense, and that may be one reason that we have grappled with both the quality and the cost of healthcare ahead of the rest of the country. Some of it is just that we're progressive and more intelligent and all of those things. But we are in a situation where healthcare is a huge economic engine, as well as the cost of healthcare being sometimes a drag on our economic competitiveness. And that's true not just in the delivery of healthcare, but in research and development, in the whole biotech industry, which is a very important part of our economic structure at this point, as well as a very important part of the intellectual capital of the world, and which influences the process frequently to try to be sure that there will be plenty of money to pay for innovation. So we have all of these forces going on here. So I'm going to do some of the history that I was going to talk about. David already talked about. I'm going to go to a few more details on that and then move on from there. So the key point here is that you will hear many people here in Massachusetts say that we did universal coverage, but we ignored the dealing with the cost element in 2006. Now, as David suggested, we did not ignore it. We said we're going to do this in stages, and I am convinced that that was the right decision. Hard enough, as we have been proving nationally over the last 3 years, to do universal coverage. If we were trying to do cost at the same time, it would have died of its own weight. And that has happened again and again. There's a great book by a Brown University history professor named Jim Marone and until recently, Harvard Medical School Mass General professor named David Blumenthal, called The Heart of Power, which was written in 2009, so before the Affordable Care Act, but which goes chapter by chapter showing how every president, beginning with my grandfather, intended to do universal health coverage while they were president as soon as the right time came. And it never came, with the one exception of Lyndon Johnson and Medicare in 1965. And indeed, my grandfather, and I've heard some of the, I didn't know my grandfather, but I knew my grandmother growing up. And so I know some of this even from her. Social Security originally had health care coverage in it. And they had to do a lot of things. You know, now we look at things like Social Security or the Civil Rights Act or something, and we think, well, it was the right thing to do, so they did it. You know, all of those things were great struggles at the time. Social Security, in order to get it passed, they had to make a lot of compromises. Some of them were very significant policy decisions, such as taking domestic workers and agricultural workers out of Social Security coverage. Why? Because they needed the votes of Southern Democrats, and they wouldn't vote for coverage for occupations that were primarily female or African American to be covered. But another thing they had to take out to do it was health care. And the American Medical Association declared it to be socialistic, as they continued to do until the year after Medicare was passed, when they suddenly just figured out how they could
make money,
work the system. I won't say game the system. Work the system to produce very good incomes under Medicare, and suddenly it became, we got to be sure we're paid enough, as opposed to it's socialistic to pay us at all. And right up to the, you know, the principal author of Social Security was Secretary of Labor Frances Perkins. She's the one cabinet member, she was the first female cabinet member ever. She's the one cabinet member that served in all 4 of my grandfather's terms. And she had also been a cabinet member of his when he was governor of New York. And she, every 2 years, every time there was a new congressional term, would try to get him to put health care back in. And he always agreed, because that's sort of how he worked. He would agree and then say, now we'll look for the right time. And it never came. So this is why, you know, you'll hear some people, they'll say this about us in 2006 here in Massachusetts. They'll certainly say this about President Obama and Speaker Pelosi and the people who took the courageous votes to pass health care in the Affordable Care Act. They'll say, why did they squander all that political capital? Why did they do it when they needed to be focusing on jobs? And they ignore that A, you can only do it when there is an overwhelming need. And people recognize the need because of the economic crisis. And you can only do it if you spend political capital at a time you have political capital. And the time a president has political capital is at the beginning of his first term. So had it not been done then, we could have gone through several more presidents who were waiting for the right time. So here in Massachusetts, in 2006, we did have and I give some credit where credit is due. We had a governor and a legislature who were prepared to do this. They may have had somewhat different motives and even somewhat different methodologies, but they were prepared to do this in 2006. And Governor Romney, I give credit for 3 things. One was that he was prepared to take a certain amount of available tax money, and rather than cut taxes, use it for an overwhelming public purpose. It's not a huge amount of tax money. Indeed, contrary to what you'll read in the national press, about 1% of the state budget is spent on universal health care. You can read an op-ed piece in the Wall Street Journal almost every other week about how our entire state budget has been swallowed by universal coverage. It's just not true. Secondly, he brought to the discussion the concept of what he called, because this was the term used by the drafters of this provision at the Heritage Foundation, the personal responsibility provision. We now call it the individual mandate, but I wish we still called it the personal responsibility provision. And he and all of us who worked in healthcare or who were progressive activists said, put a mandate on individuals, that's unfair. How can they possibly do this? And he and the fellow from Heritage persuaded us, who better to get employers to stick with this, to go and participate in this. And you know what? They were right, and they convinced us at the time. The third thing they did was hire a senior vice president who worked for me to run the program, who had it up and running in 9 months for the subsidized program and 18 months for the unsubsidized program, whereas now it's taking years to get the Affordable Care Act up and running. But so we didn't ignore it. What we said explicitly at the time, cost has to be the next act. And I think that, and because it won't be sustainable if we don't deal with cost. And as David pointed out, we have been taking those steps, and Senator Cheng Diaz pointed this out as well. We've been taking those steps. The biggest step was taken this past summer, but that was actually the third piece in a series of cost control legislation. You've heard a little bit about the transparency and the electronic medical records that were funded. So we've been taking one step after another on the cost side. But the big next step is what was taken this summer and what goes into effect next Monday. And the big deal there is something that's a little bit hard to conceptualize, but it is this cost target for the state. No state or the federal government in the United States, now this is what happens in other universal coverage countries all the time, has ever before set an overall target for what total medical expense should be in years going forward. And that's what this new piece of legislation, Chapter 224, does. And moreover, it sets a cost target that is intended to actually, yes, slow the growth of costs, but then actually bring about some reduction, and then quite reasonably says, and then there's a point at which we need to reach some steady state. We don't fully know how this has worked. That's what David's working on right now. And it's not going to be easy, it's going to be very complicated, but it is a big deal. And moreover, the cost target is not a number pulled out of the air. It is taking, I never knew this number existed before, but it's taking the gross state product, so that's like the gross domestic product, but for Massachusetts, using a sort of blended formula so you don't have year-to-year ups and downs, which is called the potential gross state product, I believe. And then saying our target for the next couple of years will be gross state product plus something, after that gross state product minus something, and then some version of steady state. And of course this will get reconsidered as we go along exactly what that ought to be, but the legislation sets out a target. It's a very, very big deal. The prediction, the calculation is that will save more than $200 billion over 15 years in total medical expense in the Commonwealth. There's a lot of other things in the bill, some assessments on insurers, which is a creative way in a legislature that has decided there can be, or particularly with a speaker who has decided there can be no tax increases for anything. Assessments on insurers in a universal coverage situation is a creative way to raise taxes without people calling it raising taxes, because who pays it? The people who pay premiums. But there's a very important prevention and wellness trust fund that has been mentioned, that is partly funded by those assessments. There's more disclosure and transparency, and there's a voluntary transition in private coverage and a mandatory transition in state-funded healthcare to global payments, using, in many cases, the mechanism of accountable care organizations. Now that's all healthcare jargon, and we can talk about it more, but the idea is to do what David is talking about. Pay for how well a group of patients is, and share those savings. Some people have moved beyond this. I spent a day last week at a day-long conference with people from all over the country, over in Cambridge at the Institute for Healthcare Improvement, which was debating who should get the savings. So they've moved to the next level to talk about who should get the savings. And of course, my answer is it needs to be enough for every party, providers, payers, employers, employees, and government, so that they will do the hard work to produce the savings. There were employers there who thought it should all go to employers, and providers who thought it should all go to providers, and that's not going to work. We've taken some detours along the way, some things that even cause people who have the same, agree on goals to have different outlooks. As we got into this debate on this piece of legislation a year and a half, 2 years ago, the Governor Patrick, decided to use the one tool that the governor had at that time to make a big point about healthcare costs growing too fast. And he froze rates of insurance companies for small group and individual coverage. Now, that was ultimately overturned by a hearing board, and that's something we had some disagreement about as it was happening. But it sure made the point. It happened that there has been, because of the economy, a downturn in healthcare usage in this country. So it turned out not to be as disastrous as we in the insurance industry painted it at the time, because that all worked together. But it made a big point about how serious the governor was in going forward with this. As this has all been going on, there actually has been movement in the market apart from legislation. If I'd been talking to you 2 years ago, I would have told you that of our total book of insured business, 17% was in these sort of global payment arrangements. Some of our plans, particularly our Medicare Preferred plan, has been in global payment forever, since they started in 1994. But overall, we had 17% in that. Now, 70% of our insured, not our self-insured, but our insured book of business, is in global payments. So that's a movement in 2 years from 17% to 70%. That insured is about half of our total business, so 35%. We're a third of the way into getting everything into global payments. That's moving, and it's showing results already. Now, if you tell them healthcare costs have not gone up as fast in the last couple of years, will say, well, that's all because of the economy. But all the time I've worked in healthcare, which does go back to the late 70s, Massachusetts has been the highest cost as measured by our premium levels of any state in the country. Now we're ninth. So we're moving down relatively with all this activity, not just absolutely, relative. We now have lower premiums, and this is just comparing premiums. We also have a somewhat more comprehensive coverage, but lower premiums than New Hampshire. When is the last time you've heard of anything that's cheaper in Massachusetts than in New Hampshire? So the market is starting to move, but again, contrary to what some people will say, the market cannot do this by itself. Healthcare usage will rebound, and moreover, the disparities in pricing among what's called the haves and the have-nots, the providers with clout versus others, will continue if there isn't the intervention. But just to give you an idea of where we are now, right now the overall trend in healthcare premiums in Massachusetts is just above 4%. A few years ago per year, increase per year. It was in the double digits. Now, as I say, I think there's several causes for that, but I think some of these efforts contribute to it greatly. For state employees, the state employees group, which is our largest group, it's about 2%. For our own employees, where for the last 4 years we've had intensive wellness and lifestyle activities, for this coming year, it would be 0%, except for implementing some of the mandates in the new federal and state laws, so it's going to be 1.5%. But just based on year-to-year comparison, we're actually at a 0% year-over-year increase from the sorts of activities we're talking about here. And it's important to remember that while transforming coverage and payment here in Massachusetts, we have continued to have the #1 hospital in the country in quality ratings, and quite a number in the top 10. We have the #1 rated health plan in the country, the #1 rated HMO, the #1 rated PPO, which happens to be Tufts Health Plan, the #3 rated Medicaid plan, which is Tufts Health Plan, and even Blue Cross is in the top 20 in the country. So we are able to we are able to maintain quality while we're making all these efforts, and while we are covering 98.1% of our citizens and 99.9% of our children with healthcare coverage. That's going to make a huge difference in the quality of life here. So if we're supposed to talk, I think, about our policy advice to the president. If I were giving advice to the president after January 20th, first of all, it would differ, of course, depending on who's president. If I were giving advice to President Romney, I would say, you're crazy if you think you can walk away from all this. If you don't deal with healthcare costs in this country, and I don't mean these silly things like malpractice reform, which is a tiny fraction of healthcare costs, or quote, selling across state lines, which simply means that Massachusetts would not have any greater consumer protections than Mississippi, and so on. No, if you really want to deal with healthcare costs in this country, you're going to have to do most of what's in the Affordable Care Act. If you can think of a way to do it without the mandate, good luck to you. No one else has thought of that yet. If I'm giving advice to President Obama, I would point out that Massachusetts didn't get to where we are and what I consider to be real progress overnight. It's been mentioned already that a number of the things that we built on started in the universal coverage legislation that Governor Dukakis sponsored in the late 80s. Many things that are in there, while it was repealed when Bill Weld became governor, many individual items were kept. Things that we take for granted, that the rest of the country considers revolutionary. No different rates for women. No, 25% higher in the rest of the country for women than for men. No pre-existing condition exclusions. No revocation retroactively because you lied on your application. Because we don't take health status applications. We just cover you. All those and many other things. Coverage for college students, coverage up to coverage of people as long as they remain dependents, and so on. Those are things we gradually did over the years. Now, the difficulty, Mr. President, is that doing this all at once is going to be hard. There's going to be what we call rate shock. All of these things cost, none of them by themselves cost a lot of money, they all cost a little money. So it took lots of hard work, time, and perseverance to get where we are. You're going to have to maybe find some ways to make this more gradual, but if you're not fighting repeal and replace and you can start making adjustments, time and hard work and perseverance can make this work. So what I would say is, don't back down, Mr. President. This can work. Start identifying what the hard tasks are and keep at it.